Hi, welcome to this video indicating how we perform a single anastomosis gastric bypass. My name's Sulman Ahmed from nepeanweightlosssurgery.com.au. We use diathermy and turn on the whole stomach count. We've already moved it out to the then up the hook. Then go over to the diathermy hook will then over to another side hole. We use a glass that stretches the hole. I'm then using an endo-GIA for another purple stapler. And then we're going to take the 6 parts, about 4 parts, and make sure that I've got a good fit with the stapler line. As you withdraw the stapler, you want to make sure that the nerve is leaning and set the stapler down. And now you do I use this a lot of people but it does form a knot and making sure it's secure. Some surgeons will use 2 OPES. There is some anecdotal evidence that it's easier to tie with 2 OPES than 3O, but I've found 3O over the years more easier in my hands. I would normally place between 3 or 4 knots, making sure I do forward and then reverse throws to make sure that I've locked the knot. Now with this technique, the assistant can then grab the superior suture, you can pull the lower thread. When using tension, you can then really see your interotomy and then making sure that you appropriately close it. I normally don't grab all 3 layers. I normally don't grab all layers, sorry. I normally will grab the seromuscular layer and we perform then a inverting or dunking procedure with the mucosa. It's important to ensure you have good bites, don't be overly aggressive, but also ensuring that you pull on the thread so that you maintain tension. A lot of surgeons are now using barb sutures so that once you pull through, the tension is maintained. Again, I don't have a problem with the barb sutures, but I've just found, again, using PDS more comfortable over the years. I just think it runs better, and it certainly probably is cheaper compared to the barbed sutures. Um, some surgeons will also place the gastric tube across the anastomosis so that they don't pick up the back wall. I later on in this video will then deploy the gastric tube across the anastomosis to do a leak test, but I generally don't place it across the enterotomy while I'm closing the hole at the same time. I usually will wait till the end, but I don't think there's any hard and fast rule. Once you have this lined up, then you can go through and through, and again, I don't think there's any concerns here. Making sure that you invert the mucosa. You can see that I've got the tail of the inferior suture caught in the suture line, but I don't think that's a big deal. You could pull it through if you want to. But again, using tension, your system pulling from the top, you're pulling from below, and that way you can then close the enterotomy well. At this point, you could just tie a knot with both threads on the same side. I don't think there's any issue with that. I always like to have the threads on opposite sides, so I will then reverse the needle and then come out the other side and then tie my knot. Again, I then generally pull up on both threads, making sure that there's tension being deployed to both threads to make sure that we're not going to have any gapes in the suture, and then away you go, and then tie your knot. Again, work out a system how you then get rid of needles so that you don't potentially have needles being left inside the patient, or more importantly, needles flicking off, and then it can be really troublesome to then find your needles. Here we are now deploying the gastric tube across the anastomosis. You'll see it pop into the small intestine. We then, using our crocomies, grab both limbs and ask the anaesthetist to inject with methylene blue. And you'd want to see both limbs expand. You want to make sure that you haven't created a stricture or an issue with either. And also you can use a Raytec to make sure that there's no leak.